I want to officially welcome Aaron to the Parkinson Support Group of Sonoma County. Thank you, Aaron.
Thank you. My name is Aaron Daley. I've been running the Parkinson's disease clinic at UCSF for about 7 years now. I work with a variety of movement disorder specialists, as well as the ancillary people, such as physical therapists and speech therapists that all sort of form our integrated clinic. We are a Parkinson's Foundation Center of Excellence, one of, I think, 46 in the world. What that basically means is that we have to continually provide a certain level of care. Our clinicians have to have a certain level of training, and that has to be maintained. We get reaccredited every 3 years, but it also means that we have access to all of the resources that the Parkinson's Foundation provides, as well as linking people to other community resources, national projects, community grants, things like that. So a lot of the slides that I will present today were actually created as part of a community grant that came from Moving Day. So I'll plug Moving Day, which is coming up this April, which is a annual thing that the Parkinson's Foundation does to encourage activity and exercise, and also as a fundraiser for these sorts of community grant programs. So we titled this Planning and Partnering for Success in Combat Parkinson's Disease. What we're going to try and cover today is just some of the, as Mark said, some of the common pitfalls that that we can avoid. So first and foremost, when we're talking about Parkinson's disease progression, we know that it does vary widely. The common saying, as everybody probably knows, is once you've met one person with Parkinson's, you've met one person with Parkinson's. And what that provides is, unfortunately, a really low predictability of progression with any sort of accuracy. The best that most clinicians can tell you is that, looking at your past might be an accurate predictor of the future. But every time that we seem to think that that makes sense, there seems to be something anecdotally which speaks to the opposite. So what we do like to do is track things like progression as it relates to the activities of daily life, the presence of new symptoms, any sort of new pain, the level of social and physical activity, general balance, things like the effectiveness of your carbidopa-levodopa treatments or other treatments, and any changes in cognition. These are the sorts of things that any movement disorder specialist really should be talking to you in a follow-up appointment. We do have what they call the movement disorder rating scale, which we use in research, primarily because we're trying to quantify the symptoms of Parkinson's to see if there has been progression. A lot of the research that we do is related to trying to slow the progression of Parkinson's. And in that way, that's why having a rating scale is very helpful. But it's not real helpful when you're talking to somebody, and you say, oh, well, your scale is a 57. That doesn't really help somebody. What helps them is, are you able to walk around the block 3 times every day? Are you able to dress yourself, feed yourself, brush your teeth, put on your clothes, those sorts of things. So that's the best way that we have of really gauging how the Parkinson's is progressing in someone. One of the issues as to the difficulty in progression is that we think that it might actually be Parkinson's diseases rather than Parkinson's disease. And that doctors may use Parkinson's as sort of a medical shorthand. And the reason is because it is so widely varied amongst people and how it manifests itself. And the fact that we have, 30% of people that never develop any sort of tremor, that some people, quite a few will develop depression or anxiety. Some people, it seems to be that their lower body is much more affected than their upper body. As well as, I think one of the more interesting things is people who actually talk about fatigue as almost being the primary problem, even more so than, the motor symptoms. So it's really hard to believe that one single sort of disease is actually causing such a wide variety of things in each person that it affects. And that's why we think that we might actually be dealing with several different diseases that all, we sort of group in this umbrella. And we just don't have the ability to drill down at the molecular level to be able to separate those out. So cognitive impairment can be an issue related to Parkinson's disease. We expect it to happen much later in progression. So, if someone is diagnosed, we expect possibly to see some form of maybe a mild cognitive impairment 10 to 15 to 20 years post-diagnosis. If it happens within the first 5 years, we start to think that it may be an atypical Parkinson's type of disease, Lewy body dementia being probably the most common one, which can be very hard to parse out from the symptoms of what they call sort of normal Parkinson's disease. And one of the big things that really is the difference is that we see cognitive impairment happening sooner than we would expect it. The kinds of cognitive impairment that we see in people with Parkinson's tend to be in the sort of executive areas. So being unable to multitask as well, but also just sort of the difficulty of things like word finding, the sort of tip of the tongue phenomenon, being distracted more easily, just needing to have, and as well as some type of delay actually in reaction, in conversation, things like that. But the other thing is that this is something that happens over a long period of time. This is not something where one day a person, is perfectly cognitively there and then the next day isn't. What we usually will see is if someone does suddenly have a real downslide as far as cognitive ability, we start to look for other things that might be causing that, infection being usually the most likely. So things like a bladder infection or a kidney infection, things where there might not actually be a lot of symptoms, that a person might notice at the beginning, but that infection is there and it's starting to sort of build up and cause some issues. The other big thing is, as I said, depression is actually really common in people with Parkinson's. And there are people who can become so depressed that they actually develop what they call a pseudo dementia. Which is basically exactly the same as a normal dementia or severe cognitive impairment. The only real difference being that with treatment of the depression, the dementia actually goes away as well. But it's something certainly to investigate to make sure that that there aren't some sort of treatable cause for a cognitive impairment. Fatigue, any one of us knows if we don't get a good night's sleep for a couple of days in a row, we certainly don't feel as sharp as we would like to. And then there are just things like, other comorbidities, diabetes, things like a thyroid deficiency. As far as treatments are concerned, I'm not a physician. I can't go too much into real medication related things other than just saying that old medications like anticholinergics have proven to be much more common in causing cognitive impairment in people, especially people over the age of about 50 or 60. That, and also that just adjusting these the carbidopa levodopa, to work best for the time when people sort of need them to work. And there are obviously some other strategies as well. One of the main things that both patients and caregivers can think about are things like, reminders and cues when you're having conversations, posting permanent notes around the house for things like phone numbers, or things just as simple as, turn off the coffee machine, stuff like that, any one of us can forget to do. But if you have someone that is starting to have some cognitive changes, what you want to do is establish a good sort of method for each day. So things like a daily to-do list that's always in the same place every single day. Having a house be organized and be consistent in that organization, so that when people go to look for something, they know that it's always going to be in the place that it's supposed to be. And writing down sequences, again, just sort of documenting that kind of stuff. And avoiding multitasking. I think that one of the things that frustrates a lot of caregivers is that they will, they'll bring up, back in the good old days when we used to go on vacations, someone would say, well, we could go to Mexico, or we could go to Europe, or we could go to Canada, or we could go to, Washington, D.C., which one do you want to do? And it's not great to throw a bunch of options at somebody with Parkinson's, because there is trouble sort of organizing and again, that executive function of all of those things. So better to offer 2 suggestions than 5. And you can certainly cover all those. You just don't want to give 5 suggestions at once, but maybe keep it to 2 at a time and break it down from there. Another thing that I really like to make sure to say is to give people with Parkinson's a chance to express themselves by not finishing sentences, or being sarcastic, if someone is taking longer to complete a sentence or a thought. And I think obviously that's something that we all should strive to do, is to give others a chance to voice, their own concerns or their own thoughts. But there is a thought within the neurological community with relations to Parkinson's that there might actually be an auditory component that is dysfunctional in the loop. So when you ask someone with Parkinson's a question, it actually takes a little longer for the processing between the auditory and then the response aspect. And that isn't obviously something that anyone has any control over, but it is something to bear in mind, that it isn't even that the person is not understanding and or comprehending or following the conversation. They may very well be, but it just is going to take a little bit more. There's going to be more of a delay in the response. One of the big buzzwords of the last 15 years is neuroplasticity. It's a fancy word for just keeping your brain engaged and active. We all need to continue to do this. One of the best ways that we can do so is doing things like what we're doing here, which is social engagement. Even if it is remote, it is still good for us. At which time we can safely gather together in person. We certainly should encourage that too, because that's one of the best ways that we have to keep our brains active and plastic. But there is a thought actually that by doing things like challenging your brain, doing crossword puzzles, doing word searches, doing all those sorts of things actually help keep your brain sort of pliable, as well as regular exercise. No one needs to be in CrossFit. They just need to go for a walk for 30 minutes a day. There are things like rock steady boxing, which I think has been really popular in the Parkinson's community in the last few years. Yoga and Tai Chi, Qigong, dancing. If anyone has seen the documentary with the Mark Morris dance group and people with Parkinson's, I think it's an amazing example of how music can actually really help us to encourage movement, but also especially in people with Parkinson's, that it seems to go around some of the issues that might be occurring in the brain and actually provide people with a much more fluid movement. So I definitely encourage anybody who hasn't seen that documentary yet that's well worth a look. But the baseline should be walking 30 minutes a day. It doesn't have to be up hills, it can be flat, but getting outside, fresh air, sunlight is really important, for warding off things like depression. But that's what everybody, both caregivers as well as patients, should be striving for. So one thing we do know is that people with Parkinson's tend to have longer hospital stays when they go into the hospital. They tend to have longer recovery times. They tend to have more complications in the hospital. So one of the things the Parkinson's Foundation has come up with is a Hospitalization Kit. And hopefully you guys are all familiar at least with this. If you aren't, let me know and I'm happy to send one to you. The Parkinson's Foundation also sends them free of charge if you just go onto their website. But basically what it comes down to is it's an advocacy kit. And one of the main problems is that people go into the hospital assuming that every doctor and every nurse knows about Parkinson's disease, and they don't. And what this does is it tells people, it educates people, and it also sort of encourages the patient as well as the caregiver to educate people about, first and foremost, medication. As we know, people with Parkinson's need to have their medication on time every time. And when they don't is when we start to see problems and complications, especially in the hospital setting. One of the main, blockades is that hospitals don't like to give medication to everybody whenever they need it. They give it out at sort of regimented times. And that doesn't work for someone who takes their medication at noon, but the hospital gives out medication at 1:30. And so what this does is it both educates, people as well as how to help themselves. The fact that people do need medication, the medication lists that are updated. I would also suggest keeping a 3-day supply of all medicines that a person might take in there as sort of an emergency backup. It is especially important for things, if people are taking things like Rytary, which a lot of hospital pharmacies don't carry yet, because it is still sort of an expensive on-brand drug. But if someone has gotten very used to Rytary and is getting a great benefit from it, you don't really want to suddenly downshift, back to normal carbidopa, levodopa if you can avoid it. And so having a supply like that, I would keep it in the original medication bottle. So with the prescription clearly marked on there, the listing of the doctor who prescribed it, just so that if anyone in the hospital does have questions about it, that it's clearly marked that the person should be taking this medication, and the doctor who needs to be contacted about it is listed there as well. So avoiding some of the most common reasons for hospitalization really comes down to, as we said, infections. One of the main problems we see with people with Parkinson's is pneumonia, in particular aspiration pneumonia. So people breathing in a piece of food, it getting stuck in one of their lungs and then forming an infection pneumonia there. The other thing, obviously, is falls. So throw rugs in the house. Hopefully you've all been told that unfortunately they may look nice, but sooner or later somebody's going to catch a toe on one, somebody's going to catch a cane on one, and it just is sort of a tripping hazard waiting to happen. Things like banisters, handholds in the bathroom, the shower, the bath, those are the sorts of things that should be just put in now. You can actually have an occupational therapist come to your house and do sort of a home safety check, which I think is good for sort of peace of mind of just, if they know how to spot things that we might not think of as being an issue. Another really simple thing that I think is overlooked a lot as I spoke about aspiration pneumonia is actually just rinsing your mouth with water after every meal. It's just a good way to get any sort of leftover particles of food that might be stuck in the teeth or in the gum line out of your mouth, and that just really can further reduce any chances of accidentally aspirating some sort of small piece of food that's left over. So we covered actually most of this already, but while in the hospital, these are some of the main problems that people with Parkinson's have. The first and foremost being the medication management, but also the need for mobility, the need to move around, aspiration again, which whether in the hospital or not can be an issue. Delirium, which sometimes is a result of maybe not having their medication or just an infection. A risk of falls or psychiatric complications. And I think I've covered all this. If you have a planned hospital stay that's coming up, you want to notify your neurologist that you're going in and let them know and ask them if they are willing to basically be contacted if a doctor in the hospital needs to speak with them about your Parkinson's management. I think it's just a good sort of easy way to give them a heads up and also so that they know to follow up with you and make sure that everything is going according to plan. So again, everyone should be an advocate in the hospital. Every doctor, every nurse, every physical therapist, every person that comes in and out of the hospital room should know that you have Parkinson's, should know when you take your medications, should know that there is a dosage time coming up. And, you know, I don't think you should annoy them, but you should certainly approach that fact with the level of information that you are providing to every single person in and out. The main problem is that, you know, you don't have a consistency in a hospital. You don't have one doctor and one nurse that is consistent there for your entire stay. You may have 4 or 5 nurses that you interact with in a 24-hour period, and they're not going to be communicating with one another about your specific treatment and your specific needs, probably at the level that you need them to. So the solution to that is to overeducate every person that comes in. So this is a quote that I like from Michael J. Fox. So what I say about Tracy is this: Tracy's big challenge is not having a Parkinson's patient for a husband, it's having me for a husband. And I happen to be a Parkinson's patient. So I like that he really has sort of flipped that, you know, as far as the dynamic between a spouse who is a primary caregiver as well as and the Parkinson's patient. But it really, it speaks to the fact that all of us have our own personalities and our own quirks and our own things that we like a certain way. And really learning to communicate and make sure that you are giving as much as you are asking in any one of these, but also recognizing that, you know, in a marriage dynamic, you know, that it doesn't matter as much that you have Parkinson's. It's just that you're treating each other with respect and feeding the things in your personalities that need to be. So as far as relationship issues that come up between people with Parkinson's and their care partners, the sort of 6 areas that they talk about, so the general closeness, the changing in roles that might happen and new identity shifts that might occur, the sexual intimacy levels, financial stress, which I think probably is the biggest source for a lot of people. Just, you know, because Parkinson's is a long disease, you know, we're talking about 15, 20, 25, 30 years. And the fact that it is a progressive illness, you know, means that there will be more interactions with medical issues. There will be more need for maybe medical devices, things like that, that come up, and just trying to plan ahead for those sorts of things. As well as just the uncertainty, you know, and I think that that's been one of the biggest problems when I have talked for caregiver groups is, you know, caregivers say, well, I don't know what to plan for. And when I ask the doctor what I should be, you know, expecting, they never really have an answer. And again, that's because none of us really can accurately predict, you know, the progression of a person's disease. So some of the challenges that we see as related to relationship issues, again, the new dynamics maybe and shifting identities, that there can be some very real communication challenges, mostly that are, you know, motor based, but that there can be emotional changes as well. And then just the thought of sort of building and rebuilding intimacy between 2 people. So one of the big issues that I hear about when I talk with people is, you know, that it sets up a dynamic that starts to look more parental than spousal, and that can generate a lot of frustration on both sides, as well as the feelings of dependency. I think none of us want to feel as though we are a burden on anyone else. And certainly not the person who we have chosen to spend our life with and made a lifelong commitment to. But that there also can be identities such as employment, you know, that may change things. I've certainly talked with caregivers who 5 years ago, you know, didn't know anything about taxes and have basically had to take on the role of being the accountant in the family. And, you know, that can be challenging. We aren't all set up to be accountants, you know, and it can be very stressful, I think, for some of us to have to take on roles that up until that point we'd had no real experience or interest. So as far as the communication challenges are concerned, we do know that people with Parkinson's do have changes in their voices. In general, they become more soft. They can become more hoarse. People can with Parkinson's can actually have sort of a slow to start, and then their speech can actually can speed up quite a bit to the point that it can become fairly mumbled, and there also is this loss of facial expression, or the masking that can occur in people with Parkinson's. And the problem with that is that we get a lot out of sort of nonverbal cues when we're having a conversation with people. Our face tells a lot as far as the engagement that we have when we're having a conversation, and it's the, eyebrows get raised, or, we make some sort of gesture, all these sort of little micro expressions that tell the person we are talking with that we are engaged in the conversation, that we are paying attention, that we are listening. And with Parkinson's, there is just a general rigidity in the muscles, including the face. And so all those sorts of little micro expressions are diminished. And the problem then is that a person speaking isn't sure whether they are being heard, whether the person is engaged, which in fact, most of the time they very well are. They are actively engaged in the conversation, but there just is a diminishment of that feedback loop that we have. And then there might be difficulty, as I said, in finding words, that tip of the tongue phenomenon, which we all experience as we get older, but it just seems to be a little more prevalent in people with Parkinson's. And what this just causes is that there is, some frustration that can occur, or maybe if a person is feeling that they have to repeat themselves. I would also say that, just getting regular auditory checks is important, because obviously all of us, our hearing starts to go as we get older too. And so it very well could be just a mechanical thing related to a loss of hearing and have nothing to do with Parkinson's. But if you have two people whose hearing isn't what it used to be 20 years ago, that are trying to communicate and having trouble hearing each other, then both of them are feeling that the other person is the one with the problem. And so it really is just important to have those sorts of check-ins as well. Some of the easy things that one can do to just sort of address some of these communication challenges. So the Lee Silverman vocal technique, or LSVT therapy, has really been proven to be very effective in people with Parkinson's. It's one of the few therapies, I think, that has survived the sort of COVID challenge as well, because it's the kind of thing that can be done remotely. And I think that the LSVT website actually advertises now that most of their therapists have video therapy appointments that are available. But what it is also just sort of maintaining voice hygiene. And that mostly has to do with doing vocal exercises, speaking from the diaphragm rather than the throat. Again, all of these muscles just start to get a little more rigid with Parkinson's, and that makes the voice softer. And but it also is just an aspect of of learning to speak with authority. Things like singing are actually really helpful in maintaining vocal hygiene, as well as facial exercises. So trying to keep the face and the muscles of the face as pliable as possible. Things that the care partner can do is make sure that they are facing the person with Parkinson's when talking, to make the ease of the communication as direct as possible. Again, all of us are losing our hearing slowly but surely, so decreasing background noise. Trying not to have loud music playing while you're trying to have a conversation. Again, facial expressions just may be a little diminished, so not necessarily relying on those when you're trying to figure out how engaged the person is. And again, being patient, giving people space to find the words and express themselves without sort of filling in the gaps, but making sure that they have a full realm of time to express themselves. And then that there are the issues related to the nonverbal communication, which I've talked about as well, but but also just that, posture can sometimes actually limit the level of direct eye contact that can occur in a conversation. So making sure that you're trying to maintain, eye contact as well. And that, sometimes people with Parkinson's need to be reminded that these sorts of things are happening because they aren't aware. And so just, maybe a reminder of like, trying not to be stooped during a conversation, but really having head up. What that also does is that opens the throat and the vocal cords, to be able to provide sort of the maximum amount of volume that can be expressed. Mark, did you want me to stop and answer questions for a little bit, or are we going to do an end of the talk?
Probably the end of the talk works better.
Okay, I'm pretty open. I like giving these talks, but I think sometimes it's more helpful for people to be able to ask questions specifically about things that they are wondering about. So I am easy either way.
One thing I hadn't discussed with you earlier, we were recording this program and want to put a link to it on our website, if that's okay with you.
Sure. Yeah, that's fine.
And for recording purposes, it may work better to keep the question.
Got it. Okay. So as I said, anxiety and depression are pretty rampant, unfortunately, in Parkinson's. And they also can impact a lot of the relationships that we have. And what we also see is that people who are caregivers of people with Parkinson's are also at an increased risk for some of these issues. How we see this play out is that we can just see a lot of extra conflict. We can see, changes in the intimacy, changes in communication, changes in the feelings of attraction that people have. As well as just the fatigue and sleepiness that can go along with anxiety and depression. And all of these negatively impact, unfortunately, our relationships. So it is important that your neurologist is asking about how you are doing mentally. And I like to encourage care partners to come to follow-up visits with a patient because care partners tend to be in the best position to answer questions that a patient might not be even realizing are an issue. And, that also sometimes we have to have a different perspective in order to kind of get the full picture. But I think it's also important to note that caregivers in particular need to pay attention to their own health and their own mental well-being as well. And that means making sure that they are keeping follow-up appointments, for their own health issues, and also just monitoring their own, mental well-being. So we're all going to play armchair neurologists here for a moment. So I was gifted a series of journals a few years ago from a lady in San Francisco whose mother had documented her husband's Parkinson's for about 7 years. And he was a scientist for his career, and he had asked her, to sort of document his progression as a way of sort of contributing to the wealth of research related to Parkinson's, as well as a way to tabulate, what his progression was looking like. It's a fascinating read. It's, I think, spans 17 different booklets. So it really became an outlet for this lady to document the day-to-day. So what I want to do is read through this, and then I'd like everybody to sort of chime in if they can on what are some of the red flags they see, some of the things that are not the best as far as the general well-being and day-to-day health. So Mr. John Doe, he wakes his wife up at 6 a.m. and he demands help from her in getting dressed. He may or may not eat breakfast. He falls asleep at the dining table. She wakes him up at 7:45, tells him to lie down. He's obstinate and sleeps at the table, or he moves to the living room chair or the downstairs bedroom and he sleeps until 11. He wakes intermittently between 11 and 1. She comes home from work. They eat lunch, watch TV. He works on his stamp collections. He falls asleep again by 3. He wakes up again at 6. has dinner, goes back to sleep, sleeps from 7:45 to about 11:30. Then he gets up, goes to bed with Jane, but he's now up and down for the rest of the evening, and awake between 1 o'clock and 6 o'clock with frequent bathroom visits. He'll either sit at his office desk, he'll sit in front of the TV, maybe he'll have short stints of sleep, and then he wakes up again at 6 o'clock and demands help getting dressed. So who here has a suggestion as to one of the things that might not be ideal with this situation?
Waking up in the middle of the night.
Right. So his sleep is all over the place.
People can unmute themselves.
Yeah.
The caregiver's going to get sick.
There's a book, Aaron, called what is it called? Putting Insomnia to Sleep, by a man from Harvard Medical, which is and the basic problem here is that he's allowed his sleep, his symptoms to develop a poor sleep hygiene pattern.
Right. His sleep hygiene is terrible.
And so it's basically habit change.
Right.
And he basically needs help either from his wife or from a professional to change his sleep hygiene. And that book, for anyone who has an insomnia problem, whether they have PD or not, is a very helpful. It requires a lot of work. It's not a simple cure-all, but if someone actually works the program outlined in that book, it can be quite helpful.
Good. Okay, so sleep is awful. That's one thing. What else do we see?
No, I'm not supposed to be doing that.
It looks like he's just eating is it one meal a day? Maybe two?
No, he's eating pretty regularly.
Oh,
but what is he not doing?
He's not exercising.
He's not exercising. There is no activity whatsoever. He's moving between the bed, the chair, the table,
Right.
the bathroom, the bed, the chair, the table, the bathroom. He's not going outside. He's not walking around. He's not even trying to get any sort of activity. Good. What else?
He's probably depressed.
Yes, he very much is probably has some sort of untreated depression.
He's not engaged socially.
He doesn't see anybody. He doesn't do anything. He doesn't talk to anybody. He basically just sits at home, works on his stamp collection, watches TV, and sleeps. Good. There's one other one there, if anybody can spot it.
He's at risk of losing his wife. She could die, or that's the real caregiver stress. And he's not putting much back into it.
Yes, he is not trying at all, and she is trying to encourage him as much as she can, but it's going to reach a breaking point at some point, right?
Yeah, there seems like there's the obstinance piece, which seems that can happen with some Parkinson's. It's just getting really stubborn about, how you're going to do things. Sometimes it's like irrational too.
Mm-hmm. And he's obstinate about things that would be better for him.
Yeah.
Yeah. Good.
And he's
excellent.
He's demanding help.
He is demanding help. Thank you. Who said that?
Marsha.
Great job. So he doesn't try to get dressed on his own. He just asks for help at the beginning. Everyone with Parkinson's should be doing everything that they can for themselves as long as they can and as long as they can safely. But the goal is to remain as independent as possible for as long as possible, not to get up and immediately start asking for help with everything. Good. You guys did a great job. So where's the independence? Where's the exercise? Where's the social activity? Where's the trying to help yourself? And the sleep is just all over the place. I will also say basic sleep hygiene. You're not supposed to watch TV if you can't sleep. You're not supposed to look at iPads and iPhones. That blue screen tells your brain to wake up. It doesn't tell your brain to go to sleep. So anyone who is getting up in the night and having trouble going back to sleep, find a very boring print article in a newspaper or a magazine, read for 15 minutes, and then try to go back to sleep. But those screens will wake you up. Excellent. So I won't dwell too much on depression just because I feel like everyone these days probably has a pretty good handle on the basic ideas of depression. Other than it can manifest itself in a lot of different ways, and it's important to make sure that we are paying attention to those, and that would be for both patients and caregivers. As well as just, I want to focus on the caregivers a little bit here, of making sure that that they understand that depression definitely can be a result of things like stress. And the danger there is that a caregiver might not engage as fully with their own health as they should be if they are too focused on making sure that the person with Parkinson's is also being taken care of. It is very important to do so, but it's just as important to make sure that you're taking care of yourself. So how can we deal with stress in healthy ways? Making sure that we can accept help, that we have a list of ways that others can help you. Again, all of these slides, unfortunately, were written in pre-COVID times. And so a lot of them, we have to have this sort of caveat with. But, being sure to focus on what you are able to provide, as well as just the realistic goals. I think that joining a support group is obviously really, really important. And can provide as well as just the encouragement and social activity, which I think is very important, is that a lot of problem solving can happen in support groups, and bringing up situations as they come along and having somebody else say, oh, we dealt with that exact same issue and we did X, Y, and Z, and that seemed to solve the problem. Having something like that from someone who understands exactly the situation you're going through, I think is worth its weight in gold.
Oh, no, it was in the bathroom.
So sleep, again, this goes for both patients as well as caregivers. None of us are going to be any useful if we don't get regular sleep, if we don't sort of have healthy situations and staying active, and maintaining that social activity as well as physical activity. Let's see. So I won't dwell too much. Just I feel like we have touched on a lot of this, but that these sorts of situations really can affect the intimacy between two people, and they do strain relationships. And the most important thing really is communication. And I know that's sort of a cliche thing to say, but without good communication, the issues are just going to pile up and they're going to get worse rather than being resolved. And I think that the best part about communication is the more that you do it, the easier it is to do it. And you can really apply those sorts of things to all levels of issues related to intimacy. What we talk about is, there are 4 different types of intimacy. We have just sort of the general time that one spend together. And again, here we are in COVID. I think we've all spent more time together than probably we ever thought that we would. And I think that can be both a positive, thing of, we know that we have survived this challenge of being with the person that we have chosen to be with a lot more than we ever thought that we would be. But I think it also is important to separate and have time that you are doing the things that you want to do. That the better that we make ourselves, the more of an engaging partner we're going to be for our significant other. As well as then just having the intimate time of emotional and physical, being able to communicate in a way, and then sexual intimacy, obviously, which, is pretty clear cut. The most important thing, as I said, with communication is to just make sure that, it isn't heavy things all the time. That you learn how to express and talk about stuff that really spans, from things that don't matter at all to things that matter very much, and making sure that you're really just expressing your own needs. No one wants to be playing the guessing game as to what it is that a person is needing from the other person. But again, the more that you get into that back and forth of communication, of really sharing what it is that what you need from the other person, the easier it is the next time that something comes up to be able to talk about it. And again, I think a lot of that just has to do with, being invested, trying to stay positive in your communication, and also trying to keep in mind, the positive attributes as to, this person who you love and you've chosen to spend your life with, that there was a reason that you did so. And it isn't just that you woke up one day and you'd been married for 30 years, but that really was, a life that you were building together. And making sure, again, that, that you have the time to do your own hobbies, but that those hobbies can also be shared with the other person. I think that a couple of the ideas that I've gotten from some of the groups I've worked with, is things like, we have these wonderful things with the internet now where you can basically find every song that you ever wanted to and instantly play it now. But, sitting and taking turns playing songs from your past that were important to you maybe, or signified a certain part of your life that you have a very strong memory with. And it has a way of developing a conversation between two people, and maybe you're playing, an old song from the 50s or something like that, and you tell a story about a time when you and your best friend went and did something, or you rode your bikes down to a, whatever, and it could generate a conversation that you've never had with a person, even though you've been with this person for 30 years. And music, I think, is just a great inroad for a lot of that kind of stuff, because it does stimulate such strong memories. We all have certain songs that we associate with a certain time in our lives. But I think that along those same lines, and these are some of the other things I've talked to with people about, is reminiscing about, two people who went on the same first date can have very different memories about that date, and it's sometimes fun to compare and contrast how each of them viewed that particular date, or what the high point was. Again, what we want to do in striving to sort of build and rebuild intimacy is to keep learning and keep gathering information about one another. Another one that I always really liked is, we all have books in our lives that we've always been meaning to read and we've never got around to reading. And I had talked to somebody who said, well, I had never read To Kill a Mockingbird, and my partner had never read War and Peace, which I feel bad for that person, but they basically traded. And so, they each read the book that they'd always wanted to read, and then they actually traded, and then they read the book that the other person had always wanted to read, as a way of being able to have that conversation. And it's amazing that two people can read the same book and have very different thoughts about it at the end. I think that, again, we do live in the age of electronics, and being important to spend time without electronics is also pretty important. So I will shift gears a little now and get into something a little more cut and dried. So one of the things I always like to highlight with people is to make sure that they know that there is an advocacy program that exists in every county in California that's called HICAP. And it basically is just a free way of finding out more information about Medicare. I worked with a social worker who said, you could spend 20 years studying Medicare and still not really understand it. And I think, unfortunately, that is very true. And the whole point of these HICAP programs is to provide information to people free of charge, to give them the information that they need specifically for their needs. And I think that that's where people get lost a lot, is that they don't want to know everything about Medicare. They just want to know about the stuff that's important to them about Medicare. And so going in, you can basically have a list of the 3 big things that you are concerned about, and a person at a HICAP program can provide that sort of information. Again, this is, you know, state sponsored, so they're not going to be recommending things which you might get if you went to sort of a private financial plan or something like that, who may have an agenda as to, you know, particular programs that they would suggest. But really just trying to find what is going to be the best, you know, program, the best coverage plans, that sort of stuff. So the contact information for your county is listed here. I can send that to Mark as well, just as an email. But that these programs do exist, and they are set here specifically so that people who have questions about Medicare can find information in sort of a neutral way. I would say also that another program is this CANHER, so California Advocates. So people that are starting to look into assisted living, just that there is this group set up, and their whole job is basically to review these sorts of assisted living cares, retirement places, with the idea that they can help people to have more information about it if this is something that starts to look like it might be a needed situation. As well as just providing legal and advocacy for families and caregivers. So one of the other things I'll talk about is palliative care. So one of the big things that in my outreach that I try to do is just to let people know that really this is supportive care. Palliative care, unfortunately, has been synonymous with sort of hospice care or end-of-life care in the past, and it really is not. So palliative, the goal of palliative care is to just provide the highest quality of life possible for patients. Why Parkinson's falls into a category that this might be a good situation is because it does progress, you know, because it is something that is chronic, because it changes in between each person. And so the needs of each person are very, you know, different. The fact that it affects many different aspects of a person's life, of a person's health. So again, so what we want is symptom management in a way that provides specifically to the symptoms that the person is experiencing. And that just leaves it very pliable to be able to be, you know, molded into the best care for any one person possible. As well as it then also just provides a net for the caregiver and the family to also be supported along with the patient. We at the at UCSF do have a Parkinson's palliative care clinic. It was run by Dr. Maya Katz for a long time. She actually has recently stopped working at UCSF, but the clinic still remains. And I would also say that the Parkinson's Foundation has actually also started an initiative in which they are trying to get every center of excellence to actually establish a supportive or palliative care clinic as part of their routine management. But just some of the ideas of where palliative care can fit in with Parkinson's disease, you know, early on is just sort of an introduction to the kinds of things provided by a supportive care clinic. You know, regular assessments, it very early on might not be anything different from what you would have in a normal follow-up. But also just knowing that as Parkinson's progresses, that the level of care and the level of interaction can also progress and provide more support for the patient as well as the family. And then this can move on to things like making sure that advanced directives are in place, meeting with a medical social worker to make sure that there are other decisions, you know, that need to be made, that are made. What we always try to tell people is you just don't want to be making big decisions in the midst of a crisis. You know, that's the wrong time to try and suddenly be, you know, signing legal forms and things like that. But then again, you know, that really starting to move into later interventions, which may be like things like power of attorney, power of medical decisions, that kind of thing. So we ran a Caregiver Series for Parkinson's, as I said, a few years ago, and you know, some of the main takeaways that I had was again that, you know, being involved in support groups, you know, are some of the best resources, especially for caregivers, of finding these sort of real world solutions and referrals, especially in local areas. and that, you know, we're not looking for something that's going to work 100% of the time, because that's just a really hard thing to find. But if we can find something that works 80% of the time, it can make a whole lot of difference in the quality of life of someone. Again, that being an advocate really is going to help open a lot of doors, whether it be in a hospital, in the clinic room. I would encourage care partners to join a patient in every follow-up appointment and just be there to answer questions, but also to be able to share, you know, what and how Parkinson's is affecting, you know, their life and their relationship with the patient. Because I think all of that information is really good, as, you know, as far as tracking progression, as far as making sure that a person is living the highest quality of life that they can. Again, the more that a caregiver can take care of themselves, the better the outcomes are going to be actually for the patient as well as the caregiver. So it really is sort of a love thyself, you know, and the more that you can take care and keep your own health, you know, in well, then the better off you're going to be able to help others. I think that making lists of questions for follow-up appointments is a really important thing. All of us, you know, think that we're going to remember all those questions, and then the second that we get into the appointment, it all drops out of our brain. And then the second that we disconnect from the call, we remember all the things that we thought that we wanted to ask. So making simple lists of questions really can make a big difference. The internet is sort of the best and the worst thing to happen to us in the last 20 years. It is great for getting information, but it needs to be information from, you know, sort of reliable sources. So things like a university site, things like the Parkinson's Foundation, things like the Michael J. Fox Foundation are all trustworthy sites. The Mayo Clinic is a good one. The problem with the internet, though, is that it's available to everybody and accessible to everybody. And, you know, people may write up their own, you know, situations and their own experiences with Parkinson's, and that is good for them to share, but it isn't something that another person can look at and then have that be sort of a good basis of data. You want this to be coming from trusted sources. If anyone ever does have questions, then part of my job is to answer those questions or find out answers from people who I can trust to provide good information about. So you don't have to be a UCSF patient in order to have help from me. I am basically a public entity for Parkinson's information. Mark, if you want to share my contact information with everyone, they can always shoot me an email, and I am happy to provide any and all answers that I can.